Well, good afternoon. I feel like a few people left, but it looks like most of our tables are still full to hear about one of the most important topics in my life right now, and certainly for many of you. So I'm going to start with a little after lunch question first. How many of you, raise your hand, work at one of our hospitals? I've seen some of you. How many of you have ever been to a hospital? How many of you have employees that maybe ever been to a hospital or have ever sought care anywhere? This is a critically important conversation now more than ever. Tiffany asked for my slides on Monday, I think, and unfortunately I obliged and sent them, and half of them have now changed since we're in the middle of a government shutdown, but we'll talk about that in just a few minutes. It's really my privilege to be able to set the stage from a healthcare landscape perspective, figuratively, but also literally for the real heroes of healthcare that'll be up on the panel to join us afterwards. But let's talk about, and I'm going to do my own slides today, bear with me, but let's talk about rural healthcare really by the numbers, and where are they showing up in? There we go. Rural hospitals in Georgia, we have 66 rural hospitals across the state that make a $6.4 billion economic impact. Hospitals in total across the state are about 122. We'll release a new economic impact number for hospitals across the state later this fall. But the rural hospitals in particular pay over $1.1 billion in salaries, employ over 16,000 Georgians across those 66 hospitals, and that's a huge, huge, significant impact. I'm thankful to Chris and the team at the Chamber for including rural healthcare in these conversations. As we talk about rural prosperity, it is time that we start viewing and talking about healthcare as infrastructure. All of you that work in economic development know that our ability to recruit and attract business and retain and sustain our communities will only be further improved by our ability to support rural healthcare. So I'm very thankful for the opportunity to have this conversation today. People always talk about rural healthcare challenges, and I want to spend just a minute talking about why there are challenges. You always hear the anecdotes of how many hospitals have closed in Georgia, but we don't often dive into why they have closed or what the real challenges are. And we've tried to break it down just a little bit, and a lot of it is about the healthcare economics or the business of healthcare. Number one is loss of revenue, and I'll show this in a slide in just a moment, but we talk about something called payer mix, or how much hospitals get paid to provide the care to patients. Oftentimes in rural Georgia, the payment that they receive does not adequately cover or compensate them up to the full cost of that care. They have increased costs. The labor markets, geography, transportation, technology, smaller population, and patient service areas with the same fixed costs often results in increased costs, and couple that with limited cash reserves where they have less ability to float when we're waiting for now a government to pay its bills, and other things really complicates the matters for rural healthcare or rural hospitals that don't have the benefit of huge urban population censuses or huge systems behind them that can help float these challenges. In addition to that, well, so let's look at payer mix for just a second. So in healthcare, payer mix I'm a data and math nerd. Part of that bio included that once upon a time I was a CFO, and so this is my favorite part. But the payer mix is a proportion of a hospital's payment structure that is paid for by certain payers. You have providers and payers, the insurers, the government fund sources. In rural Georgia, most of the patients are paid for by Medicaid, Medicare, or they're uninsured or self-pay. Roughly 70% across those 66 hospitals are patients that are paid for by a fund source that doesn't fully cover the cost of care. Now normally, hospitals try to make that up, or it's subsidized by all of us that are employed and have commercial insurance that pays a little bit better on negotiated contract rates. But there's another challenge in there. Medicare, you can see, 37% of the payer mix across those 66 rural hospitals is the single fastest growing payer for our rural hospitals. And why is that? We've got some problems. The aging population, and this is me and ChatGPT trying to play and put two charts together, but they are from credible data sources. The number of Americans turning 65, I had this conversation with one of my insurer friends recently, 10,000 Americans turn age 65 every day and become eligible for Medicare. At the same time, we're at an all-time low birth rate. So as the population is aging, and in rural Georgia, that population tends to be sicker, more acute, has less access to primary care, and showing up at our primary care and hospitals needing more complex treatments, with fewer commercially insured people being born and coming into the workforce to help subsidize that cost. And so we are at a real tipping point in terms of how that payer mix and the economics of healthcare continue to support hospitals. That's a challenge that I don't know the answer to today, but we're working on it. That leads us to overall hospital finances and what they look like. We talk about margins a lot in normal business. Hospitals, many of our hospitals are not-for-profit. Those that are not-for-profit still need a margin. It's important. They're required to provide community benefits, to invest in their infrastructure, to repair when a storm happens, to weather a storm. We've talked a lot about Hurricane Helene. And we talked to a lot of our hospitals during the storm and the aftermath, and we're thankful to our partners in the room, of course, Commissioner Harper, our friends at the EMCs and Georgia Power, who were quick to help us get generators back up and power restored. But our hospitals didn't close. They were the places that people ran to. And that costs money, and they don't get paid for that. And so when we talk about why a hospital needs a margin, that's part of it. In rural Georgia, 46% of those hospitals lost money last year. And that's not a new trend. So it's starting to hopefully paint the picture a little bit about why we have challenges in rural healthcare. That's really on the hospital side. One of the other conversations we always have is more from an individual perspective in terms of access to care for Georgians. And when we at the association talk about access to care, we really mean it's really two things: availability and affordability. If you have insurance coverage but there's no physician to go to in your community, you still don't have access to care. If there's a physician but you can't afford it, you still don't have access to care. And these issues are complicated and confounded by rural Georgia, just geography, the transportation needs, the workforce, reimbursement and payer mix that we talked about, excuse me, fixed costs to provider care, time off work for their staff. It continues to be a challenge in order to prove that. There is no, and I say this often, no single silver bullet that's going to fix, quote, access to care. We talk about that a lot, especially in Atlanta, on we need to move the needle on access to care. I talk a lot about what exactly are the levers that we can pull over here to get the outcomes that we need over here. What is the real problem we're trying to solve? It's behavioral health, and you'll hear from Sally Perry from our board in just a few minutes. Might be something different than what it might mean to move the needle on primary care, for instance. And so we need to be really specific about that. It's going to take a lot of sustained innovation, investment, and a real focus on those solutions in order to move that needle. Now, at the same time that we're facing all of those challenges that have existed for decades and are just getting a little bit worse, we also have an entirely new healthcare landscape at the federal level. I'll talk a little bit fact from fiction and talk really what happened. H.R. 1, the One Big Beautiful Bill Act, the tax working families, I don't know what we're calling it today, but reconciliation. Probably the single most impactful piece of legislation on healthcare since the Affordable Care Act was passed many, many years ago. And I want to talk you through just a little bit about how significant some of these changes are for healthcare in Georgia, and it's a little bit weedy, and I won't bore you with too many details, but I think it's important to understand the policy landscape as well, and then also some of the things that maybe aren't as impactful for Georgia and where we maybe dodged a little bit of a bullet. State-directed payments, number one, probably the single biggest impact from this bill for healthcare. Directed payments are a form of a Medicaid supplemental payment. We looked at the payer mix. The average cost in Georgia of Medicare is about 90% of cost. Medicaid is even less than that, probably closer to 70 or 75. Supplemental payments, approved by the feds, are designed to cover that gap. They're an extra payment that hospitals get with concert with the Department of Community Health and our state partners, administer these supplemental payments to try to bridge that gap. The reconciliation bill has frozen all new supplemental payments at an amount equivalent to Medicare. Any existing payments that were higher than that will face a reduction of 10% a year starting in 2028. That's a really big deal for healthcare in Georgia. When these programs first started 3 or 4 years ago, they were valued at, I think we brought in 1.3 billion new federal dollars, which was a really, really sustaining lifeline for many of our hospitals, especially the way that they were structured. When these cuts are enacted in a few years, if we're not successful in getting them pushed out a little bit, again, that all starts to roll backwards. Some other really significant impacts: provider taxes. Most of our hospitals in Georgia pay what's called a provider fee or a bed tax, up to 6% of their revenue in the most simplest of terms. There is a freeze that if you're not at that level already now in your state, you can no longer leverage those taxes in order to put up your state share of what Medicaid costs are. So when we talk about new Medicaid growth or new Medicaid programs or any conversation around Medicaid, the funding sources has now been limited and for the state to draw down those funds, so something to be very mindful of, and it prohibits any new taxes. DSH cuts, disproportionate share hospital cuts, is something that's been a lifeline for hospitals for many, many years. As of today, $250 million are cut from DSH in Georgia. Now, hopefully, when Congress starts working and we negotiate our way out of this shutdown, those telehealth we'll talk about telehealth in a minute, but those year-end health provisions, including this DSH cut, will also be extended and pushed out. It's been scheduled to be a cut for many, many years. It's been pushed out and pushed out and pushed out for about a decade. I think this is the actual time, I'm looking at our health policy chief, the first time that I can remember that it actually has gone into effect, one time. Hopefully they come back in, negotiate a deal, and these get extended. Otherwise, again, off the top, another $250 million out of healthcare in Georgia. Significant impact. One of the positive pieces out of, and I'm checking my time, one of the positive pieces out of the reconciliation package was the creation of the Rural Health Transformation Program. $50 billion across the country to transform rural health, and you'll hear Commissioner Burke talk about that in just a little bit, and I'll expound on it in just a moment as well. There are a couple more things in the reconciliation bill that are probably even the ones that were most talked about, but thankfully Georgia escaped some of those. We are a non-Medicaid expansion state, and there was, at the last few days of drafting this bill, there was some division created between expansion states and non-expansion states so that some of these provisions don't impact healthcare in Georgia as significantly as some of our other state partners. Community engagement requirements. Georgia Pathways to Coverage already offers a pathway into healthcare coverage for some Georgians. Certainly not all, there is certainly still a coverage gap, but for some Georgians that are willing to complete so many community engagement requirements. So that is a limited impact in Georgia. Minimal or no impact, there's a lot of talk about redetermining eligibility for Medicaid recipients every 6 months. But that does not apply in Georgia because it only applies to states with an expansion population. And then there was an extra 5%, a financial incentive for states to consider expanding Medicaid, and that will have a sunset here pretty shortly and something that we could no longer take advantage of. So it's a massive, massive policy and financial shift to the point of it really changes the incentives for states as they consider Medicaid and other healthcare financing programs. I'm going to share just a little bit more so you have some context when Commissioner Burke talks about the Rural Health Transformation Fund. Again, it's $50 billion from CMS with instructions to really think strategically about how not just to shore up rural health care, but how to really transform it. DCH started even before the official NOFO, or the Notice of Funding Opportunity. The grant award was released in September, but started several weeks before that, and went to rural Georgia and many communities around the state to solicit feedback. The state's application is due, I think we're targeting the end of October, officially early November. A quick turnaround from CMS if they're back open and working, but with awards by law, technically, to be announced by the end of December. Half of this $50 billion, which will be distributed equally among the states based on some formulas. Georgia is all but guaranteed or assured $100 million to transform rural health care. I think Georgia may end up being a little more aggressive in our application. There is another pot of money where we can ask for more. It is possible that Georgia ends up with $100 million or more extra dollars. So potentially upwards of $200 million or more to be invested in rural health care. And you're going to ask, what kind of healthcare infrastructure could we consider? Lots of things. There are certainly limitations in some of these categories. There are certainly opportunities for infrastructure improvements. We still have healthcare facilities that need help with generators, replacing outdated equipment, roofs. The basic things that you as a patient want to know is really shored up before you walk in the front door. Technology updates, new care delivery models, innovative other technologies that are emerging like remote patient monitoring. Some of these things will be eligible for consideration. We'll ultimately see what Commissioner Burke and the department submit for consideration and ultimately what's approved. Certainly we have submitted an application as well that they're well aware of, but really kind of a phased approach. If you went to certain rural hospitals right now and said, we'd like to update your EAR and or your EHR and implement remote patient monitoring, they'd look at me and say, like, that's great, Caylee, but I can't make payroll next week. I need to replace a roof. And so we phase this to really block and tackle first. Let's shore up some rural healthcare infrastructure first, get our folks to just a sustainable level, and then build upon that gradually over the course of the 5-year grant period so that ultimately we can move our way towards some more innovative value-based care or pilot programs that will really start to transform not just rural healthcare, but care delivery to Georgians everywhere. And so we're very appreciative of the work that Dr. Burke and his team are doing. This is a very, very robust application and submission that needs to be done in a very, very short amount of time, so we appreciate their hard work. DC now near and far? Well, right now we're shut down, as we talked about, and we are watching lots of things. Generally, Medicaid and Medicare payments will continue to all of our providers. Access to care should continue as normal, unless something really goes bump in the night or we see ourselves in a very protracted shutdown situation. There are some things that will stop. We're getting guidance, even when we were driving down this morning, CMS issued some new guidance about telehealth flexibilities and what providers can expect to receive in payment, especially under Medicare for certain telehealth flexibilities, which will become much more limited. Hospital at Home is a program where patients can stay in their home and receive care by providers. Their providers are already being instructed to get those patients moved back to inpatient statuses because that statutory authority for that program ended last night. Lots of things that we're watching, but the number one thing we're probably watching, in addition to the DSH cuts, is really the enhanced premium tax credits. And you've probably heard, if you've listened to any news station over the last week or few days, that this is one of the things that some of our partners in TC are really holding out for. Enhanced premium tax credits are tax subsidies that are available to Georgians and across the country when you buy an insurance plan off the ACA marketplace. In Georgia, we use a state-based exchange called Georgia Access. And if you meet certain income requirements, you get a subsidy, a premium tax credit immediately. For many Georgians, that results in a low or no-cost health insurance plan of a commercial nature. In fact, we've got, I think we looked on the way down, 1.2 or 1.3 million Georgians receive the benefit of those tax subsidies already. The growth in that program, Georgia Access, and the tax subsidies is something like 240% since it began. Of those folks receiving a premium tax subsidy, about 750,000 or 800,000 of them are below 150% of the federal poverty level. That if these tax subsidies expire on December 31st, as they are currently planned to do, would likely find their health insurance unaffordable and lose coverage. It's terrible for the patient, it's terrible for the community, but it also results in a significant increase in uncompensated care as those folks continue to show up in our hospitals and in our communities seeking care for which no one is now going to pay for. This is probably number one on our list for the end of the year, that these have to get extended. To put this in context, 1.3 million Georgians in Tift County, where we are today, 10% of the residents in this congressional district receive a tax subsidy. It is a significant, significant impact to those communities. It is a significant impact to small businesses who rely on the marketplace in order to insure their employees. So please keep your eye on that. Do what you can to continue to advocate for an extension of those tax credits. What can you do? This is the question we get a lot. Georgia is fortunate, and other states are now copying us, that we have a rural hospital tax credit program administered by Georgia Heart. If you have a tax liability to the state of Georgia, you can redirect up to $10,000 of it if you're married to your local rural hospital. The 50 neediest eligible hospitals are kind of indicated on the map. It changes periodically. But you can choose, instead of sending your money to the state, the Department of Revenue, you can go on, sign up, and have those tax dollars redirected to the hospital in your community. We were successful in getting the amount of that tax credit increased about 2 years ago. It's now $100 million that can be directed into that program for rural health. There is $43 million when we checked into these slides left to be claimed in a tax dollar-for-dollar credit for the remainder of this year. So if you want to help your rural hospital, this is my pitch on their behalf, please go check into this program. Call us, call Georgia Hart, call Mark Middleton back there who works with this program, and consider supporting your rural hospital. I am going to pause there. I'm happy to take questions later, but turn it over to the real experts from the field.